Welcome to the Deep Dive. This is where we take the information you want to explore and, well, we really get into it.
That's right. You give us the sources, we do the digging, find those key insights for you.
Trying to get you those aha moments, the stuff that actually sticks, but without just drowning you in information.
Exactly. Think of us as your knowledge filter.
So today, we're looking at something really fundamental in healthcare, but maybe not always obvious. The therapeutic relationship.
And our sources today are actually excerpts from a nursing textbook. So we're getting a real foundational perspective here.
Okay, so our mission, our goal for this deep dive.
Yeah.
Figure out the core ideas behind these relationships. How are they different? Really different from just, being friendly.
And why they're so critical, especially as the text points out, in psychiatric and mental health nursing.
Right. So let's start there. What is a therapeutic relationship, according to this textbook? What makes it distinct?
Okay, so fundamentally it's described as a partnership, but a very specific kind. It's goal-oriented and the focus, entirely on the patient's needs.
Goal-oriented, okay.
Yeah. The book lists some specific goals like helping patients talk about what's bothering them, finding practical ways to handle daily life stuff.
Problem solving, essentially.
Exactly. And also looking at behaviors, patterns that might be self-defeating, and then encouraging self-care. Independence.
That sounds very intentional.
Yeah.
Not like a friendship that just sort of happens.
Precisely. And the textbook really draws a clear line there. Friendships, they're usually mutual, right? Shared interests, give and take, enjoying company.
Sure. You talk about your stuff, they talk about theirs, maybe give advice.
Right. But in a therapeutic relationship, the focus is solely on the patient's issues, their growth, giving advice.
Yeah.
Usually avoided. It's more about exploring their thoughts, their feelings, helping them find solutions.
So the nurse isn't there to fix it for them?
Not directly, no. The textbook even gives this little example. It's quite telling. A nurse in a social chat offers a quick suggestion.
Trying to be helpful, probably.
Yeah, but it actually cuts the patient off, stops them from getting to maybe a deeper concern. It really shows how even well-meaning comments can be, well, untherapeutic in this specific setting.
Huh. Intent really changes everything. So, okay, let's zero in on psychiatric mental health nursing. Why is this relationship so foundational there?
Oh, the textbook is crystal clear on this. It calls the nurse-patient relationship the actual foundation of all psychiatric mental health treatment. Everything else is built on it.
Wow.
The foundation.
Yeah. And the first steps are all about creating a safe space. Safety, confidentiality within limits, of course, reliability, consistency, and setting really clear boundaries for the relationship itself.
That makes intuitive sense. I mean, trust has got to be absolutely vital, especially with sensitive mental health topics.
Totally. And while, medications and other biological treatments are important, the book really emphasizes the art of psychiatric nursing.
The art, yeah. And a huge part of that art is the relationship itself, what they call the therapeutic use of self.
Okay, what does that mean, therapeutic use of self?
It's like the nurse bringing their whole presence, their empathy, their skills, their way of communicating into the interaction in a way that specifically promotes healing. It's very conscious.
So it's more than just technical skill.
Much more. Although the text does clarify something important. Basic level nurses, they use counseling techniques within this relationship, like for problem solving, but they're not doing deep psychotherapy. That needs extra specialized training.
Got it. And this whole idea, it's not like old-fashioned, right? The book mentions a more modern take.
Yes, definitely. The idea of a patient-centered partnership is key now. It fits with the whole recovery model in mental health.
Partnership, so less hierarchical.
Exactly. It really puts the patient in the driver's seat more as an active participant in their own care, their own decisions.
What does that look like in practice?
Well, the core concepts are things like dignity and respect, obviously, sharing information openly, getting the patient and their family involved in planning, and maybe the biggest one, making sure the patient feels really heard, understood.
That feeling of being heard seems so simple, but so powerful.
It is. And this partnership, this alliance, it has real tangible benefits. The book points out how it can help ease emotional issues that often go along with things like schizophrenia or mood disorders, poor self-image, for example.
So it directly impacts symptoms.
It can improve the experience of living with those symptoms, yes. And there's solid evidence linking a positive therapeutic alliance to better treatment outcomes overall.
And the flip side.
Well, conversely, if a patient feels ignored, dismissed, disrespected, it really damages things, their willingness to engage, their progress. It makes sense, right?
Totally.
And interestingly, the textbook even mentions research suggesting, the personal qualities of both the clinician and the patient matter a lot. And get this, therapy itself, the process, can actually change brain chemistry.
Wow, that's profound. The power of that connection. Okay, so let's break it down. What are the essential pieces, the components that make this relationship work? The outline mentioned boundaries, transference, countertransference. These sound heavy.
They are absolutely key. Let's start with boundaries. The textbook explains their main job is to create that safe, predictable space we were talking about.
Predictable. How so?
Predictable in terms of roles, expectations, what happens when. So the patient feels secure enough to explore really difficult feelings, sensitive stuff, without worrying about being judged or, taken advantage of.
Where do things go wrong with boundaries?
Well, boundaries can get blurry, especially if the relationship starts feeling too much like a social one, or maybe if the nurse's own needs start creeping into the interaction.
The nurse's needs, like what?
The textbook gives a few warning signs, like overhelping, doing things for patients they can do themselves.
Undermining their independence.
Right, or controlling behaviors, making decisions for the patient, maybe thinking it's for their own good, but it takes away their autonomy. And then there's something the book calls narcissism, but in this context, it means the nurse might unconsciously need the patient to seem weak or dependent.
Why would they need that?
So the nurse can feel helpful or competent, maybe, instead of seeing and building on the patient's actual strengths.
Wow, okay. That could be subtle, even well-intentioned, perhaps?
Very subtle. Good intentions can definitely go awry here.
Okay, now, transference and countertransference. These sound like classic psych terms.
They are deep concepts, really getting into the unconscious stuff in relationships. Transference, the book explains, is basically when a patient unconsciously redirects feelings and behaviors from past significant relationships.
Like parents, siblings.
Exactly, onto the nurse. You might hear a patient say, you remind me so much of my mother when you say that. The textbook gives an example. A patient who's really critical and distant with the nurse, just like they were with a parent who was cold and critical.
So they're replaying an old script.
In a way, yes. And the text notes this tends to get amplified in relationships where there's a power difference, like nurse-patient. But crucially, not every reaction is transference. Sometimes the patient is just reacting realistically to the present situation.
Right. Got to be careful not to overinterpret.
Definitely. Common forms can be like wanting affection or respect, strong dependency, or even hostility, anger, maybe even romantic feelings. Sometimes even asking for special favors can be a sign.
Okay, so that's the patient projecting onto the nurse. What about countertransference? Is that the nurse doing the projecting?
That's exactly it. It's the flip side. The nurse's unconscious redirection of their past feelings, their past relationship dynamics, onto the patient.
And the patient's transference can trigger this.
Often, yes. Like, if a patient is constantly angry, it's natural for the nurse to start feeling defensive or irritated, right? Or if a patient is very needy and admiring, the nurse might start feeling overly important, maybe.
I can see how that could happen.
The real danger, the book stresses, is when this is unrecognized. Because unrecognized countertransference can seriously block the patient's growth.
How so?
Well, if the nurse isn't aware of why they're reacting a certain way, they might discourage the patient's independence or misunderstand their needs or just react based on their own baggage, not what the patient actually needs right then.
The textbook gives an example of this too.
It does. A nurse reacting really judgmentally to a patient's resistance in group therapy, and it turns out it's tied to the nurse's own issues with an alcoholic parent.
Wow. So strong feelings, positive or negative towards a patient, could be a red flag.
Definitely. Or over-identifying, getting into power struggles, arguing a lot. Those can all be signs for the nurse to look inward, maybe seek supervision.
Supervision sounds key here. This really highlights the need for self-awareness for the nurse. The outline also mentioned values and beliefs. How do they fit in?
Our values, our beliefs, they're like the glasses we see the world through, right? Formed by culture, family, religion, life experiences.
And we often learn them by watching others. Modeling.
Exactly. Modeling is powerful. Now, in a therapeutic relationship, you can run into trouble when the nurses' and patients' value systems, their ways of interpreting things, are really different.
Can you use some examples?
Sure, the textbook lists some tough ones. A patient considering abortion when the nurse has strong opposing moral beliefs. Or maybe the nurse feels uncomfortable with the patient's choices about safe sex, or disagreements about refusing treatment based on religion.
Yeah, those are complex.
Even things like different views on materialism versus family loyalty or substance use. The point isn't who's right or wrong. The key takeaway is nurses must understand their own values, but not impose them.
So help the patient figure out their values.
Precisely. Help them make choices that align with their beliefs and values, even if the nurse would choose differently. It requires real professional objectivity.
Objectivity, but still with care. Which brings us to empathy, genuineness, positive regard. The outline called these essential.
Absolutely foundational. The textbook firms them as core conditions for patient growth. Genuineness means the nurse is authentic. What they feel inside matches what they show outside. Their communication feels real, not like they're reading a script.
Okay. And empathy.
Empathy is crucial. It's understanding the patient's world from their viewpoint without judgment. And the book makes a really important distinction between empathy and sympathy.
What's the difference again?
Sympathy is feeling for the patient, maybe even feeling what they feel, which sounds nice, but it can mean losing your objectivity. Empathy is understanding with the patient. You connect emotionally, but maintain that professional perspective needed to help.
So understanding versus sharing the feeling.
Kind of, yes. The text contrasts them. An empathetic response validates the patient's feeling. It sounds incredibly frustrating. While a sympathetic one might shift focus. Oh, I know just how you feel. That happened to me.
Got it. And positive regard.
That's about fundamentally respecting the patient as a person. Seeing their inherent worth, believing in their potential to grow and change, regardless of their problems or behavior.
And that's shown through actions.
Primarily, yes. Not just saying, I respect you. It's shown through things like attending, giving your full focus, non-verbally signaling they matter right now.
Like putting your phone away, making eye contact.
Exactly. And suspending value judgments. Consciously setting aside your own biases to really hear their perspective. The book warns against labeling things good or bad, suggesting instead exploring the why behind the behavior.
Okay.
And finally, helping patients develop their own resources, empowering them. The textbook has these great little examples. Instead of the nurse just getting a patient a drink, guiding the patient to ask for it themselves, or helping them figure out how to ask the doctor for a weekend pass, rather than doing it for them.
So fostering autonomy, reducing helplessness.
Precisely. It builds their confidence and skills.
Okay, this is building a really clear picture. Now, how does this all unfold over time? The outline mentioned Paplaw's model, the phases of the relationship.
Right, Hildegard Paplaw's model. It's a classic framework from the 50s, but still really useful. The textbook presents it as a dynamic process, phases overlapping, all aiming to help the patient grow and become more self-reliant.
What are the main phases?
There's the orientation phase, the working phase, and the termination phase. The book also mentions a pre-orientation phase. That's the nurse's prep work, thinking, feeling before they even meet the patient.
Okay, let's start with orientation. First impressions, setting the stage.
Exactly. First meeting, big goals here. Build a rapport, that trust and understanding. Clarify roles, who does what. Discuss the contract.
Contract, like a written thing.
Could be verbal or written. It covers the basics.
Yeah.
When, where, how often you'll meet, roughly how long the relationship will last. And crucially, confidentiality. What's kept private? What are the limits?
That sounds important to clarify up front.
Absolutely. The book shows a student nurse example, introducing themselves, explaining why they're meeting. Rapport comes from showing that genuineness, empathy, positive regard we talked about, being consistent, offering help with immediate issues, and asking how the patient wants to be addressed, simple respect.
So laying down the ground rules.
Pretty much. The contract sets expectations. The textbook is another student example, specifying time, place, focus. Then, confidentiality explaining who else on the team might know things, and the exceptions like risk of harm to self or others, abuse. Clear boundaries.
You need to know the rules of the game.
Right. And even this early, especially if it's, say, a student placement with a set end date, you introduce the idea of termination, when and how the relationship will end.
Seems a bit soon, no?
It can feel like it, but it prevents surprises and helps manage expectations. The book has an example of a student mentioning their rotation end date right at the start. And finally, in this phase, you start becoming aware of potential transference and countertransference bubbling up.
Yeah.
You identify the patient's main problems together and set some initial goals.
Oh, that's a lot packed into the beginning. So once all that groundwork is laid, the working phase.
Yep, that's where the main therapeutic action happens. According to the textbook, you're maintaining the relationship, gathering more info, really promoting the patient's problem-solving skills.
Getting into the nitty-gritty.
Exactly. Building self-esteem, helping them express feelings, facilitating actual behavioral changes. You might encounter resistance here, and you work through that. You're constantly evaluating the goals you set, maybe tweaking them, and helping the patient practice new ways of coping.
New coping mechanisms. Because the old ones aren't working.
Often, yeah. The book notes that coping strategies learned in tough past situations might actually be causing problems now in different contexts, so you explore those patterns, the underlying assumptions.
Sounds like it could get intense.
It definitely can. Intense emotions can come up, anxiety, anger, sadness. Defense mechanisms might appear. And this is prime time for transference and countertransference to really show up. Requires ongoing self-awareness from the nurse, maybe using that supervision we mentioned.
Okay. And then inevitably it has to end. Termination phase. That sounds like it could be tough.
It often is for both people. The textbook really stresses it's not just stopping, it's an active part of the process. Should be discussed from the beginning.
When does it happen? Patient gets discharged.
Yeah, or maybe the nurse's placement ends, like the student example. The main tasks are summing up the progress, the goals achieved, discussing how the patient will keep using their new coping skills day to day, reviewing the relationship itself, the significant moments, insights.
It's like a debrief.
Kind of, yeah. Exchanging reflections can help with closure. But yeah, the book acknowledges it can stir up strong feelings of loss. For patients with histories of abandonment, it can be especially hard, potentially re-triggering old wounds.
But it can also be positive.
Absolutely. It's a chance for the patient to work through those feelings in a safe space, maybe for the first time. The book lists reasons why handling termination well is important. It validates the feelings. It's a learning experience about endings. It shows the nurse cared. And maybe it's the patient's first successful ending of a significant relationship.
That's a powerful thought. What if the patient gets angry or tries to resist it ending?
The textbook gives ideas for addressing that too. But one thing it's very firm on, maintaining personal contact after termination. Generally unethical. It undermines the whole process. The focus shifts to connecting the patient with ongoing community support.
Right, maintaining that professional boundary to the very end. So moving through these phases effectively takes skill. What helps the relationship flourish and what gets in the way?
Good question. The textbook points to several enhancers. Consistency is big, same nurse, regular routine, honest communication, pacing, letting the patient set the speed, listening. Really listening.
Active listening.
Yes. Positive first impressions help too. A feeling of comfort, a balanced sense of control, not too much, not too little. And obviously, patient trust and participation are vital.
And the hindrances. What blocks growth?
Inconsistency, unavailability from either side, that can lead to what the book calls mutual avoidance, where both just sort of disengage. And a big one, the nurse's own negative feelings or a lack of self-awareness. Discomfort, dislike, fear, if the nurse isn't handling that, it creates huge barriers.
It keeps coming back to that self-awareness.
It really does. And the book circles back to those 3 keys from Rogers and Kharkov.
Yeah.
Genuineness, empathy, positive regard, they're just fundamental.
Okay, so we have the principles, the phases, the components. How does this all look in the actual clinical interview, putting it all together?
Right, the interview. The textbook stresses the patient leads here. They guide the content. The nurse uses all those communication and listening skills we've been talking about to understand the patient's world.
What are the goals for the patient in that interview?
To feel safe, first and foremost. Understood. Comfortable. To be able to talk about their problems, explore them, discuss healthier ways to cope, and just generally feel like it was a helpful, satisfying interaction.
Is there prep work for the nurse before the interview?
Definitely. The setting matters. Privacy, safety, whether it's a clinic room, an inpatient unit, sometimes even the patient's home. Seating is considered to ideally same level, maybe angled slightly, not face-to-face like an interrogation. Clear exit path. No big desk barrier between them.
Small details, but they add up.
They do. Then introductions. State your name, role, purpose of the meeting, how long it'll be, reiterate confidentiality again, and ask how they prefer to be addressed. Simple but respectful.
How do you actually get the conversation started? Do you just jump in with questions?
No, the textbook advises against relying on questions, actually. Better to use open-ended statements.
Mind what?
Things like, where would you like to begin today? Or, tell me a bit about what's been going on. Use little prompts like, go on. Or, statements that show you're listening without judging. Let them tell their story.
And things to definitely avoid.
Oh yeah, clear list. Don't argue. Don't give false reassurance. Everything will be fine. Don't interpret their behavior for them. You're doing that because...
Yeah.
Don't push sensitive topics they're resisting. Don't try to sell them on treatment. Don't join in if they criticize others. Don't criticize other staff members yourself. Keep it focused, objective, on their experience.
That's a lot to keep in mind.
Some helpful guidelines are: speak briefly. If you're unsure what to say, maybe say nothing for a moment. Focus on feelings. Avoid giving advice. Pay close attention to nonverbal cues. Keep the focus firmly on the patient.
Okay. The outline also mentioned attending behaviors in more detail.
Right, those nonverbals that scream, "I'm listening." Eye contact is one, but big caveat, be culturally sensitive. Norms vary hugely.
Good point.
Body language kinesics, movement, posture, and proxemics, use of space. The book mentions typical U.S. distance zones: intimate, personal, social, public, just to show how space communicates. Vocal quality paralinguistics, your tone, pitch, speed, huge impact.
Your tone can totally change the meaning of words.
Absolutely. And then verbal tracking, staying on their topic, gently restating or summarizing what they said without adding your opinion, just to check your understanding correctly. The book gives an example of how to do this neutrally.
It sounds like becoming good at this takes ongoing effort. The outline mentions supervision and process recordings for that.
Exactly. The textbook makes it clear these are learned skills. They get better with practice and supervision. Supervision is that crucial space to talk about your feelings, your reactions to the patient, potential biases. How might they be affecting the relationship? It boosts self-awareness, sharpens skills, prevents problems.
And process recordings. What are those?
They're basically detailed written notes of specific interactions, word for word, sometimes with reflections. It's another way to really analyze communication patterns, see what worked, what didn't, especially if you can't record audio or video. Great learning tool.
This has been incredibly thorough. A real deep dive into these relationships. If you had to boil it down, what are the absolute key takeaways for our listeners?
Okay, the big messages. Therapeutic relationships are absolutely central to good healthcare, especially in mental health. They're not social friendships. They have a clear purpose focused on the patient.
And they require skill and awareness.
Tons of it. Understanding boundaries, navigating transference and countertransference, being aware of values, yours and theirs, and mastering those communication skills, especially empathy, genuineness, positive regard. They're not just nice ideas. They're the active ingredients for trust and healing.
And understanding the flow, the phases, the interview techniques.
Right. Knowing the stages, orientation, working, termination, and continuously honing those interview skills, that's how you provide care that's truly effective and centered on the patient.
That's a great summary. And for you, listening, as you think about all this, maybe consider how these ideas resonate beyond just healthcare. Think about the important connections in your own life.
What kinds of boundaries do you have in place? Are you truly listening with empathy, trying to get the other person's world?
Or maybe jumping in with fixes. This look inside the nurse-patient dynamic, using this textbook as our guide, it really offers some valuable food for thought about human connection more broadly.
Definitely does.
Thanks for joining us for this deep dive.